All right, we're going to pick up on slide 14, other cell wall synthesis inhibitors. Of course, these are all drugs that stop that cell wall from being made so the contents can be destroyed of the bacterium. Vancomycin, we are going to touch on it because vancomycin is a huge drug. It's what we consider one of the big bad boys of the antibacterial world. Vancomycin is used for a lot of the bigger, scarier bacterium. So we use it for C. diff, but when we use it for C. diff, we drink it, which is strange because it's normally an IV drug. But they mix it up like they're going to give it IV, and you drink it because C. diff is in your gut. So just to touch on vancomycin a bit, all you really need to know about vancomycin, that it's a cell wall synthesis inhibitor. It's used for gram-positive and gram-negative bacteria. We can use it for MDRs. And MDRs are a multi-drug resistant kind of bacteria. When you see MDR, it's multi-drug resistant. So things like MRSA are treated with vancomycin. Remember, it's a big bad boy. Now, vancomycin has a very narrow range of activity. So anytime we talk about narrow range of activity, that means that we're going to have to check the blood counts. So vancomycin is one of the drugs that we have to check the blood to make sure that there's a proper level of it circulating in the system, because too much can be harmful to my kidneys and liver, and not enough won't kill the bacteria. Those, I don't think they even talk about in here, but those lab tests are called a peak and a trough. One is done before you give whatever dose. The pharmacist will say, all right, before the third dose maybe, then you're going to do a peak, and then maybe 3 hours after that dose, you do a trough. And those are going to be blood tests to see how much level of that drug is still circulating in the system, because I want it to be pretty exact. I also want you to know about red man syndrome, and that's a huge one. Red man syndrome is something that's is specific only to vancomycin, and it comes from giving vancomycin IV too fast. And that causes someone to flush and turn very red. And it does talk about it in your table 5.1 on 71. It says IV vancomycin must be infused over at least 60 minutes or no more than 10 milligrams per minute to avoid Randman syndrome, which is a histamine response. Stopping or slowing the infusion will decrease the response. And most of the time when you see that in a question, it's going to be just to slow down the drug, because it happens when we give it too fast. Common side effects are nausea, vomiting, diarrhea, headache, fever, chills. They can occur. All right, we're not going to cover the carbaponyms because those are not too common of a drug. Primaxin and Merum, those are IV drugs that we give in the hospital. I'm not going to cover that because they don't even cover a lot of it themselves in under the section. The most important things to know about that is if I'm giving it IM, I'm always Z-Track, and that's with ever IM. And not much more to cover in there. All right, that's just not a classification of drugs that you see very often, but you do see vancomycin all the time. Let's see here. The tetracyclines are a huge drug classification to talk about because there's a lot of things to know about it. Tetracyclines start on 73. So we're going to look at page 73, and then I think on the next page on 75 is where you'll actually see those nice tables. Tetracyclines are one type of group of antibacterial drugs classified as protein synthesis inhibitors. A little bit different than those cell wall inhibitors. That would include tetracyclines, macrolides, aminoglycosides. All protein synthesis inhibitors, not to be confused with cell wall synthesis inhibitors, enter the bacterium and interfere with the process used by bacterium to make important proteins needed for growth. So in our cell wall synthesis inhibitors, it just stopped that wall from growing, and my bacteria was exposed and it could be destroyed. With these protein synthesis inhibitors, it actually works from the inside and keeps the bacterium from multiplying and growing. Tetracyclines are broad spectrum, it says. Adverse reactions can be some pretty serious GI upset. Drug interactions with this, milk, dairy, and calcium, they're huge to remember. You've got to remember those. And the nursing implications on this slide are hugely important as well. I don't want to give tetracyclines to anyone under 8. And I don't want to give it to pregnant women. And that is on page 74 under lifespan considerations. This drug can cause all kinds of malformations with the bone and teeth. And we really don't want to give it to people who are growing or in utero. So not for pregnant patients or patients under 8 because of the bone development and tooth development. There is a huge sensitivity to light with these medications. These people need to try to stay out of the sun. They need to make sure they're wearing sunblock. It can cause some pretty serious complications if you're out in the sun too much. What's this next one? Take on an empty stomach and avoid dairy within 2 hours of taking drugs. That is a problem with the absorption. Going back to uses, which we didn't see a whole lot of, it said broad spectrum. But under uses, it does say that we use this, and I want to point these out because these diseases are treated by tetracyclines and tetracyclines only unless there's an allergy. These big things are Lyme disease and Rocky Mountain spotted tick fever. Okay, those are tick-borne illnesses. Everybody I've ever seen that's had Lyme disease, as long as they can take it's on cyclines, tetracyclines. H. pylori is another one. H. pylori is a stomach bacterium. And H. pylori, you have to take quite a few antibiotics, but tetracyclines are one of them. Chlamydia is another, and typhoid fever. All right, but really, and anthrax. Anthrax is very strange. So those are strange things to stick out in your head that tetracyclines are used for. Let's see here. Let's look over at your table. In the table, when we say tetracyclines, what we know about these drugs is that they all end in cycline, which is good. Okay, that's easy to remember. And I think that we've covered everything under those nursing implications. Now for your macrolides, you can see that we've got mycins, azithromycin, clarithromycin, erythromycin, all very popular drugs. They all end in mycin. You guys should be remembering these psilins and cyclines and mycins, okay, for your macrolides. That's the next slide. Our macrolides are an alternative for penicillin. So patients who cannot take penicillin most often will get macrolides because remember, we don't want to give cephalosporins because they're too closely related. Some adverse reactions can be GI upset again, and that's with most of your antibiotics. Drug interactions increases the action of oral anticoagulants. So if I'm taking Coumadin, then it's going to make that Coumadin work extra over time. Dig is a heart medication. So digoxin I'm usually taking to steady out my heart rate. And usually I'm taking digoxin to lower my heart rate. So if I took this medication with a macrolide, that would make my heart rate probably too low. It does say on the slide there's many other drugs that have drug interactions. And the biggest ones that I have right now highlighted are warfarin. All right. And warfarin and dig are probably the biggest ones there. I do want to point out under uses, I've got a note to make this known as they are not effective against MRSA or some other staphylococcus bacteria. Usually if I've got MRSA, we're going to go for a vancomycin. For macrolides in your chart on 75, let's see here. It does talk about macrolides interacting with many drugs. Of course, it says to make sure with the healthcare provider, but if they're the ones that have ordered it, just make sure they know what all the other drugs are, and they should be looking at that too. My pharmacist should also be flagging that as well. The food or milk is back here again with the macrolides, just like it was with the tetracyclines. That's something to remember. And a huge one to remember for the macrolides is that bottom bullet point. Monitor your liver enzymes and assess for jaundice in patients taking macrolides because this drug can cause liver damage, especially in older people. Well, I know as I get older, my organs don't work appropriately anyway, and my liver function goes down. So all of these drugs are hard on the liver. I really need to watch for signs of jaundice because that's usually my first indication that my liver is failing. And of course, jaundice is yellowing of the skin, sclera of the eyes, and inside the mouth. And again, that's usually my first indication that something's going on with the liver. So if they look like they kind of got a yellow tint, probably should be draw some liver enzymes to check that liver. Nursing implications and patient teaching. There again, it says to make sure you're looking at all the drugs because there are lots of interactions, and advise the patient to take with food and drink extra fluids. We really want those extra fluids because we don't want it to be so hard on the liver. And because of all this GI upset is to take it with food. All right, aminoglycosides. Aminoglycosides are on page 76. It says uses aminoglycosides such as gentamicin and amikacin are used in the treatment of serious aerobic gram-negative infections, including those caused by E. coli, Serratia proteus, Klebsiella, and Pseudomonas. Those are some pretty big infections, all right? So when we saw aerobic gram-negative, aerobic means that it required air, and those gram-negative means they're hard to kill, okay? So this is a pretty stealthy classification of drugs. Expected side effects, usually when I give it by IV, it irritates my veins. And we usually see nausea, vomiting, rash, lethargy, and fever. All right, fever is a weird one because normally we don't see a fever with a lot of medications. Aminoglycosides work by being a protein synthesis inhibitor as well. So they weaken the bacteria by eliminating the production of that protein they need to reproduce on the inside. Adverse reactions. Adverse reactions are quite a few. Anytime I have a drug that's very strong, I have quite a few interactions. Nephrotoxicity means it's hard on my kidneys, my nephrons, which are in my kidneys. Ototoxicity means it can cause hearing impairment. Now, because I know this drug causes hearing impairment, then I would need to get a baseline of my patients before they start taking this drug. I need to assess how well they hear. Something on my lip. I need to assess how well they hear before they start taking the drug, because there will be no way for me to understand if it's causing hearing problems if I didn't know how well they could hear before. Dizziness, ringing in the ears, and persistent headache are some of the biggest ones. So let's see here. Make sure you understand about ototoxicity to it because it causes permanent damage inside the ear. So I definitely want to stop it if the patient has any kind of loss of hearing. Let's see here. Anything else super duper important? It also says that aminoglycosides have a very narrow therapeutic range. So this requires the blood tests. Anytime you hear of anything that says a narrow therapeutic range, then I have to make sure I'm getting blood tests. My doctor will order when those are necessary, but it's to make sure that there's a proper amount of circulating antibacterial in the blood. So far we've said that about vancomycin and the aminoglycosides. All right, so aminoglycosides, it says drug interactions. If I use it with vancomycin, then I increase the risk of nephrotoxicity because vancomycin also hard on my kidneys too. Remember we said that. So if I'm putting two drugs together that are toxic to my kidneys, then that's not so great. Ototoxicity is increased with aspirin, Lasix, and ithacrinic acid. I will not really familiar with ithacrinic acid. You'll have to look that one up. But aspirin and furosemide can cause your hearing to go away as well. So I'm taking all those drugs that are ototoxic and putting them together. And I don't want that. All right, it's going to increase my risk of having permanent hearing damage. Nursing implications in patient teaching. It's poorly absorbed from the GI tract. So that would lead you to believe that most of the time this is going to be given IV or IM. What else? Let's look at your table for aminoglycosides. It says be sure to give these drugs only for as long as prescribed because they're so hard on the kidneys and because of the hearing loss, hugely important. These drugs are always given intravenously because they don't work in the gut. Make sure you dilute them well and give them over 30 to 60 minutes. And continue to make sure that you're looking at your patient, assessing them for any kind of neurological problems, including that hearing loss, and making sure that you're looking at their urine too because of kidney damage. So anytime I have a drug that says that it can increase kidney damage, the ways that I can assess that on a daily basis are to make sure they're putting out at least 30 cc's of urine hourly and that it doesn't look too dark and have such a strong odor. Miscellaneous protein synthesis inhibitors. I don't even know if I want to touch on these, and I don't. So don't worry about slide 19 or that small little paragraph in the book, okay? We don't need that. All right, sulfonamides, sulfa drugs. We hear about these all the time. Sulfonamides are antibacterial drugs from a class known as metabolism inhibitors. They enter the bacteria and prevent them from making the final form of folic acid, which is needed for bacterial growth and function, just like our bodies. If we don't have folic acid when our mothers are pregnant with us, then we don't form right either. So these sulfonamides inhibit that folic acid from being finalized so the bacterium can reproduce, okay, and form its bacterial cells. So that's pretty cool. It's a broad spectrum anti-infective. A lot of people who are working healthcare, if they get things like sinus infections or something like that, the doctor might put them on a sulfa drug because they come in contact with MRSA a lot, but they're pretty strong. They have a bacteriostatic action, so they don't actually kill the bacteria. They just stop that growth, and they do that by the folic acid. Uses for sulfonamides. Urinary tract infections are huge, and we just talked about that. I use sulfa drugs a lot for the urinary tract infections. It says it effectively treats multiple organisms. So if I see that there's more than just one kind of bacteria, sulfa drugs are really good for these. Now, under uses is something I really want you to pay attention to. And we said right there that we use them a lot for urinary tract infections. And why we do that is because they do most of their work in the kidneys. All right. They have a high concentration of activity in the kidneys. So they're great for things, infections that actually happen in the kidney. But vice versa, on the other hand, things that work really long in the kidneys can be very hard on the kidneys as well. So I have to watch that. It says I can use these for urinary tract infections, particularly cystitis, pyelitis, and pyelonephritis, which are all infections of the kidney or the urinary tract. I just have to make sure that I'm really watching my kidney function because they do work in the kidney. So for that reason, I'm going to have them drink plenty of fluids. It does say that we can use sulfonamides for respiratory infections. We might use it for pneumocystitis or pneumonia in patients with HIV. Lots of reasons, but my main reasons are for things involving my urinary system. Expected side effects are minor but irritating. I feel like probably a lot of those is probably that diarrhea. So you might see fatigue, dizziness, insomnia. Anorexia is a big one, loss of appetite. Your drug interactions are a few. They potentiate oral anticoagulants, which that means that makes them act over time. So if I'm taking an oral anticoagulant, then I'm not going to coagulate very well at all. Methotrexate, sulfonylureas, thiazide diuretics, phenytoin, which is dilantin, and urosuric agents all do not work well with my sulfonamides. Nursing implications, make sure you're really looking at that photosensitivity. That means they might have a problem with bright light. It might be hurting their eyes. And I should take these medications on an empty stomach. There's more I want to touch on here in sulfonamides before we go into fluoroquinolones. Sulfonamides crystallize in the kidneys and can cause kidney damage. Remember, we said they work the most in the kidney, and because of that, we have to watch the kidney. And there again, we need to drink plenty of fluids. And it says allergic reactions to sulfonamides are pretty common. Under drug interactions, we already did those. I just wanted to make sure there's nothing else we need to touch on. We said the severe photosensitivity, and it does say that sulfonamide should be taken with food or milk or full glass of water to minimize stomach irritation and to prevent the formation of crystals. Drinking plenty of water to flush out the kidneys. All right, fluoroquinolones. Fluoroquinolones are on page, I don't know where. Oh, they're on page 77. Fluoroquinolones destroy bacteria by inhibiting two enzymes needed for DNA synthesis and reproduction. They are a type of bactericidal DNA synthesis inhibitor. So they go in and destroy. So they destroy the DNA so they can't make any more. So they are bactericidal. They are effective against gram-negative pathogens. Remember, those are the hardest ones to kill. Let's see here. It says the newer ones are more significantly effective against gram-positive microbes as well. So that would be your second, third, fourth generation drugs. Let's see here. Adverse reactions, it kind of skips over expected side effects, but it says for patients who dribble urine, this is important, or who are incontinent, the skin in the genital area can become red and sore. This problem is reduced by having the patient increase his or her fluid intake to dilute the urine. So if they're dribbling urine, then that means that there's going to be high levels of this drug coming out, because if I take a drug in it, I have to eventually excrete it, all right? Or the drug would just build up every time I took it again. So in this situation, then it's very highly concentrated in the urine, that it can cause problems with the skin if they happen to dribble or if they're incontinent and it stays on them. Adverse reactions are arthropathy, which is joint pain. Let's see here. And it says that can occur especially in children who are receiving fluoroquinolones. It does talk too about the rupture of tendon, and I really want to pay attention to that one. That's at the bottom of adverse reactions. It says rupture of a tendon in the shoulder, hand, arm, or wrist, or heel can occur. Typically, we see that in the heel, and that's especially in patients with decreased renal function, older age, and those taking prednisone. Hugely important to remember that one. And it does talk about that I have to adjust the dose if my patient is in renal failure. So because it's excreted by the kidneys, I want to make sure that if they're having kidney problems, then they probably don't need as big a dose as most people do. All right. They might need it, but they can't take it because of the renal function. To continue with fluoroquinolones, drug interactions are multivitamins, mineral supplements. They reduce the absorption. That happens a lot with multivitamins. That happens a lot with things like Tums and Maalox as well. So this is one of those drugs that if I take a multivitamin anytime within taking the fluoroquinolone, then my medication, my fluoroquinolone, won't work as well. It also says it increases anticoagulant effects of warfarin, so I can overcoagulate, or excuse me, I can not coagulate very well at all. Okay, I'll be very, very thin. Nursing implications and patient teaching. Take with food to decrease the adverse effects. We've already talked about that. Keep your older patients well hydrated. Then it has to come with the effects on the kidney and how much it actually is excreted by the kidney. Touching into the drug interactions, just a little bit about that multivitamin again. It says take your multivitamins. Take this fluoroquinolone at least 2 hours before or 4 hours after a multivitamin. Minerals, antacids, or iron, because it reduces the absorption. All right, so skipping 25 and going to anti-tubercular drugs. Now, the biggest thing about knowing things about anti-tubercular drugs are not really particularly every single drug. There's a couple I want you to remember. But most of it is that we're taking lots of medications and they have to be taken very particularly. So an overview of anti-tubercular drugs, what we see here is we usually see tuberculosis in underdeveloped nations. We do still see tuberculosis in the States. And there's a higher concentration of tuberculosis in things like prisons. But tuberculosis we really do see in places that we would consider to be like third world countries, much more than we see here. The risks of getting tuberculosis, there's plenty in the book. A high risk of people living in low socioeconomic status, living very close together, make you at higher risk for TB, and that especially people who are homeless. TB is something that we won't get into a whole big lot here. You probably did that in respiratory already. But remember, there's latent and active TB, so it could just be that I've got TB and don't know it for a long time. And what's important to know about TB, too, is that it can form that tubercle. So it can attach to the inside of your lungs, and a wall can form around it, and you really don't see anything happening for a long time until that bacteria rears its ugly head, okay? So we want to really talk about the anti-tubercular drugs. I do want you to read page 79 on it, just to review yourself about what tuberculosis is. You know that it's an airborne infection, just to jog your memory, all right? And then we get over to, on 79, the first line TB drugs. Actually, we can go ahead and go over to the next page in 80 and talk about the anti-tubercular drugs. The actions and uses of these drugs, it says most anti-tubercular drugs are bacteriostatic, which means they inhibit the growth of any more, inhibit them from making more, doesn't actually kill it. In the end, it renders it gone, but it takes quite some time. It's not like bactericidal. They have an intracellular or extracellular effects that prevent the organism from building new cells, thus limiting growth and the spread. All right, so they're like not letting my wall build. They're not actually going out there killing. They are bacteriostatic. Some antitubercular drugs are bactericidal. There's a few of each. We won't get into those specifically. I'm more concerned that you know the regimen they need to take the tuberculin drugs. The length of treatment is quite long. And if I can find it, I believe it is about 18 weeks. Let me look through here. There's a regimen in here somewhere. Yeah. All right. It's actually 8 weeks and then 18 weeks. And we're going to talk about that just in a minute. So 18 plus 8 is 26. So 26 weeks of therapy, taking medications, lots of medications daily. And chemoprophylaxis, I'm not horribly familiar with, and that's not my goal for you to understand the TB drugs. If you come across it in here, familiarize yourself with it. But I am more concerned about the regular medications. And I don't even see the chemoprophylaxis in here, to tell you the truth. All right, so don't give too much focus to that. The next slide, adverse reactions of all these antitubercular drugs that are listed on page 80. There's a lot. It depends on which drug it is. And we're going to talk about those a little bit individually. Toxicity, there's lots of body sites that can be affected. We use them in combination. There's a lot of these drugs. Let's see here. How many do we use? We're going to go to page, actually, let's go ahead and start on 79 at the very bottom. It says, the first line TB drug therapy recommended by the CDC is the use of INH, rifampin, pyrazinamide, and ethambutol for the first 8 weeks. So there's 4 drugs they have to take daily for 8 weeks. And then after that 8 weeks, they have to take INH and rifampin for 18 more. So for the first 8 weeks, all 4 drugs, and then for the 18 weeks following that, just INH and rifampin. So I really want to look at the INH and rifampin. Looking at iocyanide or INH on page 80, it says it kills actively growing mycobacteria, which is the tuberculin, outside the cell and inhibits the growth of the dormant bacteria inside the macrophages and granulomas. So what that's doing is breaking that down so I can't make more and more and more. All right, it's not letting it grow, and it gets inside of those areas where it's just kind of laying dormant or latent, and it gets in there and it kind of takes care of it. And that's why the INH is a drug that you'll take the whole time. For nursing implications, it's important to know not to take the antacids, take the drug on an empty stomach. Let's see here. Teach patients to take multivitamins that contain B complex vitamins or vitamin B6 while taking this drug. That's important. Remind the patients to avoid drinking alcoholic beverages while on this drug because of liver damage. And I do want to point out that all the drugs that we use for tuberculosis are very highly liver toxic. They're hepatotoxic. So I'm really, really watching that liver. So any kind of other drugs that could be very hard on the liver, I'd want them to stay away from. And you know, alcohol is very hard on the liver, so we really want to stay away from that as well. I want them to tell me if they have darkening of urine, because that signifies a problem with the liver. Okay, that goes back to being jaundiced. So if my urine gets really dark orange, then I know that there might, actually when it gets dark orangey brown, then I might know there might be a problem with my liver. So I really want them to take to make point to look at the urine as well. And I want to make sure that I'm, with all these, of course, making sure that I take note of all the drugs that they're on. The other drug that I want to point out is the rifampin, and it's the other drug that we take the whole time as well. Remember, we take INH, rifampin, pyrazinamide, and ethambutol all of the first 4 weeks, and then the INH and the rifampin for the 18 weeks after that. And rifampin is a weird drug as well because it turns just about everything in my body kind of orangey. Even if I wear contacts, it turns the contacts orange. So what I want to look at is the implications for rifampin as well. Instruct the patients to avoid antacids and take the drug on an empty stomach, just like before. Warn the patients to expect a reddish-orange staining of the skin, urine, and all other secretions. Now, because these drugs are hard on the liver and I'm taking INH at the same time, then it might be hard for the patient to understand when it's just normal for their urine to turn orange and when I'm looking for liver failure. And the liver failure is going to be more orangey brown, whereas the rifampin is just going to kind of turn it orange. We see about the soft contact lenses there and not to wear them, making sure they're not drinking any alcohol or doing anything else that can damage their liver. They're reporting the darkening of urine because of we're looking for that brownish orange stuff for liver failure. We want to make sure we're also telling the patients who are diabetic to check their blood sugar levels frequently because it can cause fluctuations in their glucose levels. That one's another one that's hugely important. It also says, too, that we can use the IV route only if oral is not practical. And I will say something, that most of the time doctors like to give oral drugs unless it has to be something that has very quick actions, because a good rule of thumb is if the gut works, use it. So those are the two drugs I really want you to focus on when it comes to tuberculosis. I do want you to know the names of the ones, okay? But the complications and nursing interventions or implications mainly for the INH and the rifampin. Anti-tubercular drugs continued. We see on this slide there's lots of use of other drugs during therapy. We have to make sure that we're paying attention to those because we're watching those liver functions and all the interactions. Nursing implications and patient teaching, assessment. And what I want you to know about assessment, we've pretty much covered. Really teaching them how to pay attention to the signs of liver failure and jaundice. Diagnosis, of course, this is back when you're learning about TB, but I'm going to get a history and physical, of course, from this person. If they've been around anybody, what socioeconomic status are they living in or they have shelter, all this good stuff. Of course, I'm going to do a TB skin test in most situations, but that's not definitive. That just tells me if I've been exposed to TB or not. If I have, then I'm going to have to get a chest x-ray. And what they're looking for in the chest x-ray is that tubercle, that large mass inside of the lung. And I'll probably get some other blood tests as well to confirm it. Planning, it's definitely important to talk to your patient about how long they're going to be taking these drugs and that they have to take them continuously in the exact way they're supposed to or they will not work. It's a lot of drugs. It could be pretty costly. Remember, there's help out there for them to get their medicines paid for, but they have to take them like they're instructed to take them all the time, at the same time, all the time. Evaluation, of course, to evaluate any kind of effectiveness for any drug, we're going to be doing labs and follow-up x-rays. That's about, I think, all we need for that. Patient and family teaching, of course. Not only do I need to teach them about how to help them with their drug regimen, but I also need to teach them about ways to get themselves safe from tuberculosis, all right, from the tubercular patient. Okay, so there need to be quite a bit of education about how to live in the home with someone with tuberculosis. Antifungals are on page 83. Antifungals are medications that stop the growth of yeast or molds. In your book, it says here that most of your fungi, and we talked about this last chapter, are opportunistic infections. And you don't really see those unless my immune system drops. And that happens quite a bit in my older patients or my HIV patients, or even when I'm on an antibiotic. Let's see here. I want to talk about the word mycosis or a mycotic infection. If I see those words, then I know mycosis is a fungus, okay? It says uses for antifungals. We treat mycotic infections. Fungal-specific medications, if it's yeast, then I'm usually using a drug called nystatin. And that drug can be used in cream, powder, swish and swallow, spray, depending on where the yeast is. So I think for the yeast in the growing area for men, jock itch, that may be a spray or a powder. Athlete's foot is yeast, and that's usually a spray or a powder. Women can get yeast infection underneath folds that stay sweaty. Yeast likes to breed in warm, moist places. And I will tell you that yeast likes to thrive on sugar as well. So those sweet people might get yeast more often too, those diabetics. I fell asleep with a cough drop in my mouth once that wasn't sugar-free, and I got yeast from it. So they like warm, moist place and sugar. So I can also get fungal infections systemically, and that means I can get a fungal infection in my blood. And one of those things that I like to think about when it comes to that is Stevens-Johnson syndrome, and that's something we'll talk about another time, or you may have already talked about it in MedSurge 1. But I can also get systemic fungal infections too. So depending on where that fungal infection is how I'm going to treat it, all right? Now, if I'm going to use a nystatin powder on a patient, and maybe it's under a breast fold or a stomach fold, I have to make sure that I clean that area with soap and water and pat it dry before I ever put the powder or cream on. So if there's powder or cream already on it, that has to be removed and cleaned very well. And then I can go ahead and I can apply my new powder after I patted it dry, new powder or my new cream. On the bottom of 83, something else I'd like to point out. We talked about those people that have opportunistic infections. We talked about the people with diabetes. Pregnant women, sometimes their immune system's quite low because they're trying to fight for two people. So that could be common with pregnant women. It also talks about women on birth control, patient taking corticosteroids. That's a huge one because remember in the past we said that not only does antibiotics drop your immune system, but corticosteroids do as well. And corticosteroids can raise your blood sugar quite high as well. So you got a double whammy there. You're super sweet and you have a low immune system with a corticosteroid. All right, flipping over to the next page on 84. We're also looking at transplant people. We didn't think about that one. My transplant people taking those immunosuppressive drugs, of course, have a lower immune system because we want them to be. So those people might be at high risk for fungal infections as well. So actions of an antifungal drug are used orally, intravenously, topically, vaginally, and they're to treat a variety of fungal or mycotic infections. And we talked quite a bit about those. If it's for a fungus, it can either be fungostatic or fungicidal. And that's the same way as bacteriostatic or bactericidal. It can either kill the fungus or inhibit its growth so it eventually dies off. Okay. Common antifungal medications. These are going to be over on table 5.5. Your azoles. This is a hugely popular classification of antifungals. Your azoles work by altering the cellular membrane of the fungus by depleting a lipid-like substance, which damages the fungus and will not allow it to reproduce, so eventually it dies off. At higher doses, azoles will kill the fungus. They are used to provide prophylaxis in high-risk patients to treat topical and systemic infections caused by candida. Candida is yeast, and other fungus that are susceptible to their action. So it even says sometimes I can give it prophylactically, and that means to give it before anything's ever happened to try to keep it from happening. The most common drug here that you've probably seen before is fluconazole or diflucan. Diflucan is commonly given to women in maybe a one-pill format to treat a vaginal yeast infection. But under nursing implications, it doesn't even talk about diflucan or fluconazole on your slides, but it's definitely an important drug. Definitely want you to look at the second bullet point. Instruct the patient to monitor for rash, redness, or blistering because this could indicate a serious medical emergency. If these symptoms occur, they must notify the healthcare provider immediately. This could be a sign of something called Stevens-Johnson syndrome. And Stevens-Johnson syndrome is on 84 under expected side effects and adverse reactions, which I don't even think we even had a slide for. But skin reactions, rashes, and rare serious rash such as Stevens-Johnson's can occur when taking these drugs. This actually happened to Nurse Potter's mother. Stevens-Johnson syndrome begins with a painful red or purplish rash, blisters, and flu-like symptoms. It is a medical emergency. It is a systemic fungal problem, okay? And it's caused by the antifungals, so definitely a medical emergency. It says on a couple of bullet points down, to instruct patients on oral antidiabetic drugs to monitor glucose levels closely because these drugs can cause fluctuations. Monitor blood urea nitrogen or BUN. BUN is another drug that's specific for your kidney. And that's going to show me how well my kidney's working. And so is your creatinine level. So when you see BUN and creatinine, those are going to be kidney-specific labs, all right? We want to check those because these drugs are kind of hard on the kidneys. We also want to check the liver functions because they're also hard on the liver. So I'm going to be watching those labs closely when patients are on azoles. And you notice that both of these drugs end in azole. All right. Tell the patients to report yellow, light-colored stools, dark urine, and yellowing of the eyes and the sclera because these could be adverse liver reactions. Remember, we talked about these before. If anything's hard on the liver, I'm going to be looking for those discolorations of things. At the bottom, it also says, teach sexually active women to use effective birth control while taking azoles because these drugs may cause birth defects. So we definitely don't want a woman getting pregnant while she's on these drugs. It's strange to me that the slide talks about ketoconazole, even though I feel like fluconazole is more popular, but about the same. They're the same classification of drugs, just a little bit of a chemical difference in makeup, but same nursing implications. All right, so nystatin, we're going to skip grasofulvin because we don't really, it's not really popular, but we're definitely going to talk about the nystatins, okay, because we use nystatin continuously. Nystatin alters fungal cell membranes by depleting the lipid-like substance, which damages the fungus and will not allow it to reproduce, so it will eventually die off. At higher doses, it will actually kill, so it works as a bacteriostatic and bactericidal. Our big drug here, of course, is nystatin. The whole classification is named after it. Our nursing implications here, we only want to prepare a single dose of the nystatin powder for suspension because it does not contain preservatives and will not stay fresh. Teach patients to shake the suspension because it will separate. Teach patients to take half the dose in each side of the mouth to completely cover the oral tissues. So if I have an oral nystatin, oral yeast problem, I'm going to get a drug called swish and swallow or swish and spit. Just depends on if they want you to swallow it or not. And that means that my mouth is covered in thrush or yeast. And I want that medication to get in my mouth and swish it around, get it between my gums and my teeth and my lips and my teeth or whatever. Hold it in my mouth, make sure that I've got some on both sides. And I want it to sit there for a minute so it can work, all right? And then the patient will either spit it out or swallow it. And I don't want them to go rinse their mouth out. While the drug is sitting there, I want it to stay there for a little while. It says that in here too. Make sure you're talking to patients that are using the swish and swallow who have diabetes because there's quite a bit of flavoring in that swish and swallow, and it's sugary and it might cause their blood sugar to go up. And I think that's pretty good. I do want to talk about, there's grasofulvin. We're not going to talk about that. I do want to touch on Flagyl. Let me see if I can find where it is in your book. Flagyl is a drug that we use quite often as an antifungal. And I don't see it in your book at all. I don't see in your book. Try to find Flagyl in your book. It says related to drug for mixed fungal and bacterial protozoal infections, and it interacts with alcohol. Flagyl is something that we normally give IV, but I don't see it in the book at all. So, but it is a popular drug. I do really want you to pay attention, and we won't go through, but just a couple of things on box 5.3. That is patients using topical antifungal drugs and how to teach them to use it and how for you to show them how to use it. So that, I can't go into that in specific because we're getting way too long here, but you've got to pay attention to box 5.3. It's extremely important, all right? Lots and lots of important stuff in there, okay? We talked about some of it. For the foot area, make sure there's powder in between. For vaginal creams, make sure, usually you want to give it before bedtime so they don't run out. Just read the whole box, all right? It's very important. All right. Your anti-parasitic drugs. We'll touch a little bit on those. Anti-parasitic drugs. Actually, I think I'm actually going to have... No, we can keep going. We'll just keep going. This will just be a long video. Your anti-parasitic drugs. We're going to talk about anti-amebicides, anti-helmintics, and anti-malarials. We'll go ahead and skip down to the Let's see, what are we going to go to first? We'll talk about the protozoa, all right? Let's see. Yeah, anti-protozoals are first. We'll talk about those. Protozoa, amoebiasis, giardias are usually contracted from food and water contaminated by feces or unwashed hands after using the bathroom or changing a diaper. Giardia, usually people get it who are hiking and they drink from a stream or something, and animals have defecated in there, and they usually get this horrible, horrible, horrible gastrointestinal upset. It's really, really bad. It says these infections reside in the intestinal tract, and common symptoms are horrible diarrhea, abdominal pain, vomiting, and foul-smelling stools. Toxoplasmosis is usually asymptomatic in healthy individual, but can cause serious illnesses in people with chronic disease and people who are pregnant. Toxoplasmosis, I usually get it from contaminated soil or cleaning cat litter boxes. Trichomonas is a sexually transmitted disease, and it is sort of looks like chlamydia. It causes burning, itching, redness, vaginal or penile discharge in massive amounts, like lava. Malaria is a common Southeast Asia and common in Asia and Africa. I get this from mosquito bites. It's spread through the bites of mosquitoes, have been infected by malaria. The parasite migrates to the liver where it matures and then enters the bloodstream. It lives and produces in the blood, using hemoglobin and nutrients inside the red blood cells until the blood cell ruptures. So very, very, very serious. Anybody who is going to Africa or Asia usually has to get treated prophylactically with an antiprotozoal so they don't get malaria. So an anti-malarial drug. Uses for those antiprotozoals, they work in several different ways inside the cell, affecting the function of DNA or RNA to kill the protozoan parasites. Your next slide says actions and uses. We just talked about that. They destroy all those invading amoeba. Amoeba are little tiny parasites, so that's pretty disgusting. We talked about the intestinal and extra-intestinal ones. We talked about everywhere those are when we covered the amoebiasis, giardias, toxoplasmosis, trichomonas, and malaria. Drug of choice depends on which kind of amoebiasis it is. So we really want to look at those drugs. So we're going to look at those on page 89 in the box. 89 in the box, we're going to really look at there's Flagyl. Woohoo! I don't know why it's all the way over here. I love Flagyl. Flagyl is a very fantastic drug. We use it for a lot of things. Over-nursing implications for these antiparasitics. These are not antimalarials. You notice it says it beside there. We have specific drugs for antimalarials. They say it works in several ways inside the DNA or RNA to kill the protozoal parasites. Flagyl, teach your patients to swallow. Flagyl, extended release tablet. You remember, it can't be crushed. It has to be swallowed whole. Make sure you give 1 hour or 2 hours after meals, before or 2 hours after meals. Take with a full glass of water. Make sure that you're looking at their baseline liver function and kidney function, all right? Because it's hard on the liver and kidneys if I take it for an extended amount of time. So I want to see what their liver and kidneys look like before I started taking it. So I have a baseline. I want to know if it makes it any worse. Remind patients taking Flagyl to avoid alcohol because alcohol is also hard on your liver, and so is Flagyl. Let's see here. Anything else jumping out at me here? Nothing jumping out at me any more than that for that. Your antimalarials, these are drugs that are prophylactic or to treat malaria. We see here chloroquine and primaquine. Primaquine is probably the most popular of the two. That's the one that I've seen the most. I can do these, and it gives you the different dosages. You don't have to remember those, but you see they both can treat malaria or they can give prophylactically for someone going out of the country. The things that jump out at me here under nursing implications, of course, read them all. But I want to, third bullet point down, warn patients with psoriasis that chloroquine can worsen psoriasis symptoms of red scaly skin patches. Watch for any personality changes because it can affect your central nervous system. People who are taking valproic acid or digoxin for their heart may need more frequent drug levels drawn because chloroquine decreases the valproic acid levels, increasing the risk for seizures, and increases digoxin levels, making risk for dig toxicity. There again on our liver functions, we need to make sure we know how the liver's working before we do it, and we're really paying attention to the liver too. Sometimes this causes liver swelling, it says, and normally you could barely palpate the outer edges of your liver in your right underneath your right rib cage. So if you can palpate the liver and feel the liver pretty good, then you know the liver's probably swollen. Antihelminths, and a helminth is a worm. They destroy worms by paralyzing the parasite, killing it, and dislocating its adherence to the host site. So if it's in your gut, you'll poop it out. Biltricide. Let's see, take with food and a glass of water. It can be damaging to the liver again. I don't know if you've seen already in this chapter, there's lots of things that can damage the liver. So I'm really paying attention to the liver function tests. Tell patients with a history of cardiac dysrhythmias to contact their healthcare provider if they are dizzy or have irregular heartbeat. I would tell a patient with a dysrhythmia to pay attention to that anytime they take a new medication. So those antihelminths are to get rid of the worms. Let's see what else we need to. Antimalarials. Let me look under antimalarials again, because on chapter 39 there's quite a bit there. Let me see if anything else jumps out at me for antimalarials. Not that I could even find it right now. Antiprotozoals. I think we've covered just about everything that's most important on antimalarials. We did talk about the dermatological effects. We didn't talk about autotoxicity, so throw that one in. Could also be autotoxic. And we did talk about the CNS changes. Let's see here. So under the antimalarials too, I know we're taking a step backwards, but on slide 40, it talks about evaluation. And when you think about things, when it says, how do you evaluate, think about what we were given the medication before to begin with, all right? So, and also think about the things that it's most hard on. So if I was giving a drug like an antimalarial to get rid of malaria, and I know it's hard on my eyes and it's hard on my liver, when I go to evaluate, of course, I'm going to do labs and diagnostic testing to make sure the malaria is gone. I'm also going to watch my eyes, and I'm also going to watch my liver. And that's how I evaluate the effectiveness and what any kind of side effect that the medications cause. Those are both very important things to remember when you're looking at evaluation. What did I use it for? And what were the things that I could really mess up with it? And those are the things I need to be continuously evaluating. Enter your antihelmintic slide. It talks about common infestations, the common worms that we see: pinworms, roundworms, hookworms, tapeworms, whipworms. The most common out of all of those are pinworms. Pinworms are little tiny worms that like to wiggle out of your rectum at night while you're asleep. In the old days, people used to put a piece of tape over a child's rectum to try to catch them as they come out so they can verify that they had pinworms. But those are the most common type. So if you've got those kind of worms, you kind of do want to clean your toilet seats and, just don't want to pass them around. But usually when you see pinworms in the house, a lot of other people have them too, which is totally gross. Hookworms are a type of worms that you can get through actually your feet, walking in like pastures and stuff. Worms are just gross. You don't want worms. Blah, blah, blah. And I think in a nutshell, we got it all, guys. So I'm going to go ahead and upload this one, and then at some point in the morning, I'll be working on the next chapter. These videos just take a long time to upload. Remember, you don't have tests till next week, so you can review over and over and over. All right, talk to you soon. Bye.